Welcome to the new requirements for counties in the Drug Medi-Cal Waiver webinar, presented by the California Institute for Behavioral Health Solutions and the California Department of Healthcare Services. I now turn it over to Dr. Will Ratmarskel.
Well, good morning, everyone. Welcome to this webinar. It's a series of trainings and webinars that we're providing at California Institute for Behavioral Health Solutions on behalf of the Department of Healthcare Services on the Drug Medi-Cal Organized Delivery System Waiver. We've done some, if you did not hear them and would like to get information how to access them, we held one that kind of gave a general overview of the waiver, and now we're doing some other webinars that are going to be focused on specific topics related to the waiver. So the topic for today, the focus for today, is the new responsibilities for counties and providers. We'll really be focusing on that aspect, not necessarily talking about all of the waiver and all the components of the waiver. For that, if you want that general orientation, again, please feel free to let us know, and we will be glad to send you the information to the previous webinar that we had. So what I'd like to do now is turn the presentation over to our presenters. We have Victor Kohler, he's Vice President here at the California Institute for Behavioral Health Solutions, and Thomas Renfrey, he's Deputy Director of the Substance Use Services County, over Substance Use Services for the County Behavioral Health Directors Association of California. So we're pleased to have them here and help us figure out as it unfolds, as it gets clearer and clearer over time, what some of these new responsibilities are. So Victor, Tom, thank you for joining us.
Well, thank you, Will. It's good to be back here. And I would like to start off with something from if you're on our last webinar, I mentioned that this is going to be really a transformational process, truly transformational. And this webinar will get into some of the details of those transformations will be. And I just want to show a couple slides from last time about the required services. These are what will be the components of your organized delivery system in Drug Medi-Cal. First off, there's withdrawal management, at least one level. That could be outpatient or residential. One level, we talk about level, we mean ASAM level. One level of residential services, intensive outpatient treatment, opioid treatment programs, recovery services for people with completed treatment, case management, and physician consultation. And it's consultation generally with other MDs in, say, the mental health primary care settings. There are, in addition, there are optional services, county options, medication-assisted treatment, which include antabuse or buprenorphine, and then recovery residences. Their facilities will be funded by the grant, which what we are currently calling transitional housing, where there is some supervision and the requirement that residents participate in treatment, and the treatment would then be Drug Medi-Cal funded. I'd like to turn over to Tom Renfrey for a second here to talk about some access considerations.
Yes, good morning, everyone. Am I coming through okay?
Yes.
Okay. Did you want to say something about the optional service first, Victor, or want me to go ahead and?
Yeah, no, go ahead. Go ahead. That's
okay.
That was sort of confusing.
Well, as counties are considering opting into the waiver, and we certainly encourage counties to do that because this, like Victor said, this is transformational. This is probably the biggest thing that has happened, improvement in our Drug Medi-Cal system ever. And it's important to remember, however, that the county implementation plans are still in draft form. They're not finalized yet, even though the department is pursuing a rather aggressive timeline to get counties involved. There is some work still going on with regard to the county contracts and county implementation plans. So, and as you'll see as we move into this, CBHDA, whom I represent, has made some recommendations and has submitted some comments, which are public comments now, to the department regarding some things that we would like to see perhaps modified in the or further explained in the county implementation plans. But I think the one big consideration that we're looking at is around the requirement that counties that participate in the waiver have to assure access to all covered services. As you know, Drug Medi-Cal is an entitlement program, which means that beneficiaries, all eligible beneficiaries, are entitled to all covered services when medically necessary. And the timely certification of providers, therefore, is really essential to the success. As you know, this is a demonstration waiver, and the goal is to show how an improved and organized delivery system for Drug Medi-Cal is going to be a real benefit to the state and counties, and especially to beneficiaries. And so, but that's going to be dependent on the ability of counties and the state to develop an adequate network of providers to ensure timely access to care. And the state and the county should take the appropriate steps to ensure that all participating counties, that's all counties that opt in, have an effective process to be able to certify providers in a timely manner. As many of you are probably aware, the certification of new providers has been rather slow in rolling out. The department is working on trying to expedite this process, but you know, we still have a lot of new applications that are somewhere in the pipeline, and I know it's been a little bit perhaps frustrating for some providers with regard to the application process. I'm not here to talk about that process, but just to emphasize that it's important that we get an adequate network of providers, because without that, you know, counties are not going to be able to assure access to all the covered services. So CBHDA has made a couple of recommendations to the state. Again, these are recommendations, and we'll see where they go from here. But we've recommended that counties participating in the demonstration, opt-in counties, should have the responsibility to certify the providers in their county, to issue the certifications for non-county providers. The state would still, in our recommendation, the state, of course, would still certify county programs, but counties would certify their contract providers. And we think that this is workable because, you know, all counties have you know, certified mental health providers. They've already got systems in place to be able to do the certification for mental health providers. And now that most counties have integrated behavioral health departments, we believe they can leverage the already established certification process in place for mental health to be able to certify Drug Medi-Cal providers as well. If the state still you know, wants to be involved or partner with the counties in the certification process, we would recommend that they expedite the process for providers in the demonstration counties. In other words, for those counties that are ready to opt in the first wave, our recommendation is that there be an expedited process to certify providers in those counties so they can get started. And we've also recommended that the department agree to meet certain timeliness standards for certification. So again, we're still continuing to work at counties. You know, we're working with the department on this. They have been favorable toward trying to expedite the process overall and move to you know, they're in the process of moving to an more electronic system for looking at applications. They've really done a lot recently in providing technical assistance and training in how, you know, for providers how to complete you know, good applications, and we're just hoping that this that this kind of attention continues. But anyway, those are our recommendations at this point. So I'll turn it back over to Victor.
Okay, thanks, Tom. What we're going to talk about today are where these new requirements and responsibilities and roles come from. We talked about the waiver terms and conditions in our last webinar, and those are under review at CMS. We expect approval by the last week of March. The next element is the county implementation plan, which is going to be the major focus for today. The counties have to submit a plan to the Department of Healthcare Services describing how they're going to implement key aspects of the waiver. There is then also the state-county drug Medi-Cal NNA contract. This contract exists and has existed for some years, but there will be some major revisions of the contract to drug Medi-Cal for counties participating in the waiver. And it's pretty technical, but I'll go over what the sort of the highlights are there. And last was federal regulations, and those are even more technical, and I'll provide an overview to that. We can, if there's interest, follow up after the webinar and maybe send these materials out to people who are on the webinar now. So for the implementation plan, now this is a draft plan, and I think as Tom was saying, this is all still pretty fluid at the moment. But the elements in there are, and I'll go through these. First off, the counties have a collaborative planning process, and they need to describe what. Yes.
I'm sorry, Victor. Several folks in the audience are saying that your voice is kind of breaking up. Is there a way that you could bring this microphone closer to you so your voice comes through stronger?
Yeah, I'll try. Maybe I'll, yeah. All right, sorry. So the planning process and the DHCS has listed a potential set of stakeholders, which would include drug treatment providers, physical health care providers, FQHCs, county public health, social services, county executive office, law enforcement, courts, probation, education, and others if desired. And the county will describe how all these entities and interested stakeholders in the community will participate in the development of the plan and how ongoing involvement will occur. I would think there are a few counties that still have substance use advisory boards, and I think this could be a good role for them. Otherwise, there's going to be a bit of a learning curve bringing together a new group here with issues around membership, authority and oversight, governance, and the role after the waiver plan is submitted. There's the language in the instructions, leave it open whether that ongoing involvement is required or not. But in each county that will be a decision to see whether that's desirable. So, Tom?
Yeah, and I'm just following up on that last point that Victor made. We've heard from some counties that the draft implementation plan still lacks clarity in terms of whether counties have to adhere to specific planning guidelines. In other words, is the department going to say you have to have this many meetings or this many stakeholders, this type of stakeholders represented? What are the time frames for local review and comment? Is the department going to specify that, or are they going to allow local needs and structures to be the basis for local planning? We would certainly recommend the latter, that local, because counties are very different, that they allow for local needs and structures to be the basis for local planning, and just give some overall guidelines in terms of you have to have stakeholder representation, but we would prefer that counties be allowed to make some of these decisions. So, but that's still kind of unclear right now in the draft plans.
Okay.
And we've had a question. I don't know. I think we've maybe moved past it, but it might be good if I put this question out for you for a second.
Sure.
And see if you want to answer it now or later.
That's fine.
There were two questions about intensive outpatient treatment. So one is, are some counties currently contracting and paying for IoT services under drug Medi-Cal?
Yes, because that was one service that actually has already been expanded in the state plan. So we're not, because it's now in the state plan, counties are providing that service and being able to bill for it under drug Medi-Cal.
Okay, and the second question was, will IoT services be excluded as entitlement services under drug Medi-Cal in counties not participating in the waiver? No,
just the opposite. Because it's any benefit that's in the state plan has to be provided statewide. So that means that whether or not a county participates in the waiver, every county is still responsible to provide the benefits that are covered in the state plan. And IoT is now one of those benefits.
Okay, and then lastly, go ahead.
Oh, I was just going to say, Victor, I don't know if you wanted to add anything there, but.
No, that's correct. I mean,
okay.
Yeah, it's part of the state plan. It's part of the standard drug Medi-Cal benefit structure. And
right. And remember, the waiver is exactly that. It's waiving things, so it's not bound to the state plan. But anything that's specified in the state plan is an entitled benefit that has to be provided in all counties. Go ahead, Will. Sorry.
Oh, and then lastly, there was a comment back to where you were on the implementation plan and the planning process. So I just wanted to catch up on that backlog and bring us back to where you are right now. So this last one was, yes, it's an important point for someone wanted to say, a very important point for accountability and involvement of communities. What that local, I assume that's referring to the local planning process.
Right. So that was just a comment that they were
just a comment. Wasn't
affirming. Okay.
Yeah. Affirming it. And then, but back again to the IoT, the person said no one at the state of Orange County knows anything about contracting for IoT services in Orange County.
Well, I would be a bit surprised if there's not somebody in the department there that knows in Orange County, that knows how to contract for IoT. I'm assuming, there have been some limited IoT services that have been provided for years, not to the extent that they are, going to be entitled to now, but we've always had limited IoT, for example, for perinatal or youth under EPSDT. So I'm assuming, and again, I don't work in the county, so I'm just assuming that the county would know how to contract for those services.
Okay, and maybe that's something they could follow up with you if this is someone from the county or if this is a provider. They might be able to follow up with you directly, right, Tom?
Yeah, that would be good. If you could follow up with me, I think my contact information is provided, and then I'll connect you with someone in the county that might be able to help.
Okay, great. Okay, go ahead.
Okay, so client flow, and you'll recall from earlier discussions here that the ASAM patient placement criteria are a fundamental component of this. That placement initially in care and moving through the system are determined by the ASAM criteria. So the county needs to describe how clients will move through the different levels of care in the organized delivery system and how they transition to different levels of care. So, if you're familiar with ASAM, there's different considerations there. There's initial placement, there's criteria for continuing stay or transition to another level of care, and then ultimately discharge, which I wouldn't say is discharge, but rather it's the final transition to self-directed recovery in the community, which isn't an ASAM, but it's it's something that's part of the process. So and in some ways this shouldn't be too big a departure. I mean, treatment is about movement, from addiction to recovery. It's a process. It's change over time. It's not, it's something where we try to move clients in a respectful but what to say, organized fashion to recovery. So the question here is how the system is organized and operated. So there's two things. How's it organized, sort of static composition, and how's it operated to ensure the clients are in the right place at the right level of care at the right time in the treatment and recovery process. What this will lead to, though, is different relationships that exist now in most counties between counties and providers, where counties will exercise more oversight over clients' entry into treatment and their experience in the treatment system, and also among providers. If you're a detox provider, the residential provider is going to have an interest in what you do, and vice versa. Residential, their referrals will come from detox, and likewise throughout levels of care, that there's somebody, or a place where clients are coming from and a place where clients will transition to. And unless you're a large organization that does it all internally, you as say a standalone outpatient provider are going to have to have very different sort of relationships with your colleague providers in the county. Okay, next item here is describing the treatment services. What are the required and optional types of services provided? Are there barriers with required services? I mean, for example, do you have an NTP program? What about residential? Is there some part of the county, if you're to draw a map, where there's kind of a blank spot, where you don't have any outpatient or anything? And the state recognizes that this is going to be work in progress even when counties, do opt into the waiver. And so it's, there's a planned transition to how to get this fully ramped up. But there's also, how does the county plan to provide state plan services? And this is what Tom was talking about. These are the standard pre-existing drug Medi-Cal benefits, which since last year now include intensive outpatient for any eligible client. So how do you provide those state plan services? Because people reside in a county that is not participating in the waiver cannot go to a waiver county in this enhanced menu of services. They're only eligible for state plan services. And Tom, there's a CBHDA recommendation there.
Right. We have recommended that as part of the question, the state describe what the expectations are for serving out-of-county beneficiaries. We think that's the language is still lacks some clarity on this. As you may or may not know, under the waiver, we'll be moving from a county of service to a county of residence provision of services. So basically the county is responsible to cover to provide the covered services for all beneficiaries who reside, whose residence is in that county. The question comes up, of course, what happens if people, as so often happens, people from one county receive services in a waiver county. Perhaps the county they're residing in is a non-participating county, but they're receiving services in a participating county. We just think there needs to be further clarification about how that, or vice versa. If a county, someone residing in a participating county goes to receive services in a non-opt-in county, how is that all gonna work? And so, but it's clear that counties are going to be responsible for their own residents, whether they're opt-in or opt-out.
Right, and And I think there's, at least the guidelines currently stand, is that it will be the provider's responsibility to determine the client's county of residence.
Correct.
And so they may not, if you're a provider,
I was saying they can't hear you.
I think it's, all right, so that it appears to be that it's going to be the provider's responsibility for determining the client's county of residence, and I would speculate that you wouldn't get paid if you provide waiver services to a client who lives in a non-waiver county. All right, so the expansions we talked about, what are the elements of the organized delivery system, and so how are you going to expand services to include all levels of the ASAM criteria over the period of the waiver? What is the timeline for expansion? I mentioned that, the state recognizes, there's probably only, who knows, maybe a few counties who are probably ready to go like now. They have all the pieces in place. And the thing here is, this is the question I think that comes up is, what if the gaps lie in residential capacity or NTP services? There's we can expect to see some pretty significant NIMBY issues. I think this will be challenging for many counties to expand residential capacity or medication-assisted treatment, and will be something that may be a good role or something that the community advisory body could get involved in. One thing that's, I've said before is that our field is kind of operates in a data desert, and one of the things that we don't know very well is how, for example, how many residential beds do we need per 100,000 population? How many NTP slots? How many outpatient slots? We don't have good population health data and the corresponding linkage to treatment capacity. So some of this we're going to have to take our best estimates at, and then as we go along, make changes and improvements. Tom, I think you had a comment here on.
Yeah, we did have one comment. There's one question that we have a concern about because it seems to imply that all participating counties have to bring all ASAM levels of service, including those that have been identified as optional in the terms and conditions. This is an easy fix. We just think that they need to be add language, stating that only the required services are counties need to provide, and also that make it clear, as they've stated in the terms and conditions, that you don't have to provide all levels of residential care. You just have to provide one level. The same with detox. The county doesn't have to provide all levels of detox, just one ASAM level. So we think that's a pretty easy fix, but that this question in the implementation plan does need to be changed. Otherwise, if you're going to imply that counties have to provide all levels, including of ASAM services, including optional ones, that's obviously a huge fiscal impact, both for the state and counties. So that's the only comment we made on that.
All right. So next here we've got the plans to discuss integration with mental health and with physical health, and how the county is going to integrate services there. Again, I think impacts for providers. They're the folks who are actually, at least in many counties, you've got community-based organizations who are actually doing the work of direct services for people in treatment. And for mental health, I think there are two pieces to this. One is you've got the county mental health plan, the SMI population. How do we integrate services with them for beneficiaries, clients with co-occurring disorders, and then also with county health plans who now have responsibility for reimbursing services to the mild to moderate mental mental health population. I think that we're going to see that the SMI group will predominate in the mental health plans, and we'll see referrals come from them to the SUD system for the most part. And the mild to moderate is likely to predominate in the SUD and primary care caseloads, and the referral flow in the other direction to for physical health. I think we'll talk about this a little further on, but the health MOUs required. The health plans are going to be important. This will be the roadmap for how this will happen, how clients will be referred back and forth. It's a bidirectional thing, and how care is coordinated. There's issues of electronic health records, confidentiality that need to be addressed here, and we're talking also more about just aspirin or Suboxone. There's clients who be out with hepatitis C and who have chronic conditions needing ongoing care. Access here, I'm not going to go through everything here. Every one of these people, you'll have this for reference afterwards, but access is a huge issue in the waiver. CMS wants to be absolutely sure that there's no decrease in access, that access to services are not limited. Hopefully they expand, that it doesn't shrink. And so counties have to discuss the anticipated number of Medi-Cal clients, expected utilization of services, the numbers and types of providers needed to purchase those services, kind of what we were talking before about population health and related capacity, hours of operation, geographic locations, and I think there'll be need to be thinking about some sort of standards here about language capacity, time limits to appointments, hours of operations, geographic location. And when I was putting it together, I was thinking, if you were open a convenience store, you wouldn't be open just 9 to 5. And what does the customer want? We've got a whole different situation now. I think much smarter than the waiver. We are in the process and just beginning to develop an entirely new relationship with the caseload who used to have, in many cases, court order hanging over their head. And we do not have the number of mandated clients like we used to. And so we have to, what to say, provide better customer service. And, if we're not open on the weekends, if we're not open in the evenings, why not? People need those services. Any other business, and I think we need to be thinking of ourselves more in business terms these days, is going to be available at times in places and ways that are convenient for their customers. And in a fee-for-service world where the drug Medi-Cal client is, in a sense, paying their own way through the Medi-Cal reimbursement, they are our customers, and we have to make sure that we're giving them good access to care in the times and places and ways that they need it.
Okay, I got a question or a comment. Is this a good time?
Yeah, this is okay.
Sure.
Can you please note the requirement that clients be able to seek and receive services at a given contracted provider without having to go through a central intake process?
Ooh, I think I'm going to talk about that a little further on.
Okay.
I've got some content on it. That's a big issue.
Yeah.
Okay.
Was that it, Will?
Was that all?
That was it, other than the continued comments about, Victor, you're speaking louder, getting closer to the microphone, because your voice cuts in and out.
Okay, well, I'm not sure what I can do here.
Did you
I'll
want to
continue to speak as well.
Did you want to try going back to speaker like you had tried before? Maybe that will work more consistently better. Let's see.
All right, well, how is this then? Any better?
Might be more consistently the same. At least it won't have the fading in and out. let's go on and we'll see if we hear from more folks if they can't hear you.
Yeah, let me jump in here. While Victor's working on that, I don't think we can overemphasize how important this issue of client access is. I mean, this is something that CMS is looking very closely at to make sure that clients have timely access to covered services. And I think our comments that we've submitted from CBHDA, we continue to stress the bidirectional accountability of this. Yes, counties do need to assure beneficiary access, but the state also has a responsibility on this access issue, because this is a statewide program. Even though it's going to be expanded in the participating counties, Drug Medi-Cal is still a statewide program, so the state does have some accountability here too. And we think the best thing that the state can do to help out in this area is to either, as I'm repeating myself, but either to allow counties to certify their own providers, or to expedite the process of certification, especially beginning in those counties that are going to be opting into the waiver, because it is, it's just absolutely essential for client access that we have an adequate provider network. And so that is something we continue to stress. Back to you. Yeah.
Related to that, I think there's a comment about no wrong door policy means a client should be able to access at any point, and they wanted to ask if that was correct.
Well, they can, some of that's going to be, and maybe Victor will talk about this under that issue, but some of that's going to be a county issue as to whether county has a central sort of a screening, central intake process, or whether people can go to any provider. But there are going to be some abilities for counties to do authorization. So I think we'll just let Victor speak to that when he gets to that point.
Okay, and then maybe
we'll get to that.
And then maybe you'll get to also, there's another one, address the issue of reimbursement for room and board under residential services.
Yeah, I think that's included in a future slide.
Yeah.
Okay, and then someone else agreed with you. Must expedite providers to get certified through the state. Not.
Yeah.
Oh, well, necessary, and then not counties. Counties may restrict access. So someone was concerned about county certification.
With counties certifying providers, you mean?
Yeah, saying here that counties may restrict access.
Well, they can't. They're not allowed to do that under the terms and conditions. That's very clear that counties cannot restrict access to any entitlement services.
Okay, great. We're caught up. Go ahead.
Good, Victor. I'm turning it back to you.
Okay, so back to another issue about access. And this is in the contract, in the application, the implementation plan, and in the federal regulations, is having linguistic capacity. And this table is a summary showing the number of counties where the language listed in the left-hand column occurs at the threshold level, which means you've got to have services available in that language. No surprise that Spanish is at the top of the list, and then you can work your way down, see, Vietnamese, Cantonese, Armenian, Russian, Tagalog, Hmong, Farsi, Cambodian, and I have a report we could send out if people are interested, showing county by county how this lines up. As it shows there, 49 out of 58 counties have Spanish as a threshold language. If you're in LA County, I think you've got them all. But something to think about here is that you may have other languages that may not hit threshold levels, but are of concern in your county. There may be languages not even on the list. Southeast Asian languages. In India, there are 22 official languages classified by the Indian government. There's diversity in among the Spanish speakers. For example, LA County has 63% of the California population of immigrants from El Salvador. Culturally, it's not the same. There are some differences in the way the language is spoken, particularly colloquially. You have other issues like Armenian, which is a threshold language in LA. You may have places like Fresno, where the Armenian community is large, and if I were in Fresno, I wouldn't say, well, you don't meet the threshold, so we don't have to do this in your language. I don't think that's something that anyone would really want to say. So, but this is what we've got to do. This is the minimum here as far as meeting linguistic capacity in programs, and that clients are able to access services in their language. And I have to say, this is more than just a regulatory requirement. This is something that is fundamental to building trust and credibility in non-English speaking communities. So I don't, like I said, we can send out the entire report from DHS showing county by county how this lines up, but these are this is a summary wide.
And yes, several people are taking you up on that offer, so we'll do that for everyone.
Sure, I'll make a note of that. Okay, more the implementation plan, counties have to say what kind of training will be offered to providers, what kind of technicals that they will offer to providers, what kind of technical assistance will the county need from DHCS, and that's let's say it's a big learning curve for everybody, and I'll just draw your attention to that logo in the bottom left. We plan to be involved and to help out at whatever level we can, both with providers and with the counties. Quality assurance, and I think this is really important. It is, what I see this is that we need to move beyond compliance, and we've been sort of mired in that in drug Medi-Cal for, about a year and a half, 2 years now. But to get beyond compliance and get into the quality agenda. And we've got to have, of course, we have to have compliance. That's the foundation for everything. But once we do that, once you make sure that, every session has a progress note, then how good is it? What are the skills of counselors doing the group counseling or individual counseling? And so the counties have to describe the quality assurance activities that the county will conduct. What's the monitoring process? What does the Quality Improvement Committee do? Who are the members on that committee? And, this is one element where we are, if you look at particularly at the contract, you look at all these other documents, we can see that the drug Medi-Cal waiver is moving the SUD treatment system closer to the mental health plans. Many of these requirements are the same as exist for the mental health plans. This is particularly in the contract language. And so, for example, the MOUs would be the state DHS has said, well, the county can just, add on to the mental health MOU with the health plans instead of creating a new one. Same thing here, that this could get folded into the quality assurance structures that exist in the mental health plans. My thinking here is to, keep it simple. Certainly at the beginning, there are some, key issues as far as program performance, client outcomes are concerned. I think of like NIATEX, some of the NIATEX issues, engagement and retention. If you've got a quality assurance plan that's got 39 different goals and objectives, I would, you got to ask yourself, can we really do this all? And I always say it's better to focus on a few things, do them well, do them right, and once you've got those under control, move on to the next, move on down the list. And Tom, there was a CBHDA comment here on this?
Yeah, there's a recommendation that if the state does have specific QA activities that they're, going to require that they should outline those so counties are clear about what the expectations are. Counties, the department has now provided that counties will be reimbursed for administrative costs related to QI and QA activities. I don't think they've issued the final bulletin on that, but we've been assured that that there is going to be a reimbursement process set up for counties to be reimbursed for those costs. But we would like to, know a little more specifically if the department does have certain activities that they are going to, say you should do if you want to be reimbursed. We need to know what those are.
Okay, thanks. And I would suggest too that quality improvement doesn't begin and end with the county. That there needs to be staff and structures at the provider level to make sure this all happens. And with similar concern about cost and reimbursement. Again, in the implementation plan, there's a requirement that providers are implementing at least 2 of the evidence-based practices that are outlined in the, I think it's in the terms and conditions. These are motivational interviewing, cognitive behavioral therapy, relapse prevention, trauma-informed treatment, and psychoeducation. And as I've said in the previous presentation, the implementation of evidence-based practices, to do it correctly, you don't go to a half day or a full day training on motivational interviewing and assume that's done, that you've handled it. Even aside from staff turnover, the people who've been doing research on motivational interviewing find that it takes ongoing support, ongoing supervision, things like videotape sessions, feedback from either trainers or clinical supervisors at the program level before before staff can be considered truly competent in that. So we're going to do evidence-based practices. We need to do it right. We need to follow through on it, make sure staff are fully trained, that they're supervised, and really know how to do this in a whole variety of situations with clients. The next question, I think, is an interesting one. What action will the county take if the provider is found to be in noncompliance? And a good question. What do you do? New York State, in their substance use department, has an Office of Outcomes, and they changed the name after a couple of years to the Office of Outcomes and Technical Assistance, because they realized that if the state was not getting the desired results, then what the first thing to do is provide additional support. The first response is not to say, okay, we're going to pull the plug, we're taking your contract, and that's that. Because really who gets penalized there is not the provider so much as the committee. And so the first response, at least for me, would be what kind of support does this organization need to be able to come to the required levels of performance? And it really becomes as much the county's responsibility as the providers to do this. And like I say, this is me, but I think the first response should be, how do we help? How can we help you make the grade here to improve the standards?
Before you move,
yeah.
Before you move on from evidence-based practice, there was a couple comments about that. One was, please repeat the EBPs you listed.
Oh, all right. Those were motivational interviewing, cognitive behavioral therapy, relapse prevention, trauma-informed treatment, and psychoeducation.
And then someone else asked, will the state assist us on how to measure if the EBPs are effective?
I'm glad somebody asked that question. That's a good question. I am that should be part of the implementation process. And I think that's, I think ultimately a provider perspective. My thinking on evidence-based practices is once you're doing it, you need to be collecting data, which does, goes well beyond calones. Is this having the desired impact? So, first off, you have confidence that staff are adequately trained and supervised in delivering the evidence-based practice. But secondly, are you managing that? And I think what happens is you go to, I'm exaggerating here, but you go to the, the 2-day workshop in cognitive behavioral therapy, you come back and now you're the expert in the agency, you maybe train other staff. But you're not, how do you know it's working? How do you know you're getting the desired effect, with your clients? And if you're a program manager, are all your staff equally skilled in applying it? Some may be better than others and get better results with clients than others do. So I think it's really, you're flying blind if you're not capturing data on how your clients respond to treatment. So maybe the state has a role in there, maybe the county does, but ultimately it rolls down to the provider level to be able to implement these evidence-based practices in a thoughtful and informed way.
Okay, and then, gosh, I don't know if someone is asking you again to repeat the 5 EBPs, which you just did. I don't know if these are coming in late or they didn't hear you just repeat them. But then it says, in which at least 2 are going to be required. I think maybe that's the twist on that question.
Yeah, so I mean, there's a list of 5. I'll go over quickly again. Motivational interviewing, cognitive behavioral therapy, relapse prevention, trauma-informed treatment, and psychoeducation. And providers have to implement at least 2 of those. Now, whether every provider has to do the same 2 or or it gets spread out, I don't know.
That's not clear in terms of the which 2. Okay, great.
Yeah.
And then there was one other comment back around access that was about also focusing on not just language, but ethnicity, race, LGBTQ.
Yeah.
So I think those are things that should be considered also in terms of access.
Oh, absolutely. Yes, and I should have been. I'm sorry that I omitted that. I got sort of wrapped up in this threshold language numbers this morning. But yeah, you're right. I mean, if we look at culture broadly, it's a lot more than folks who came from other countries or speak different languages, and particularly LGBTQ people, and I mean, there's all sorts of groups, and you need to be thinking about that. And the advisory group could be helpful in that regard. Who are the folks that we need to pay special attention to make sure who may be at higher risk than the rest of the population, or just need some sort of special attention to access. And I think that's very important. We have to be respectful and honor everybody in our communities. And we can't exclude people because we don't have people who, I will say metaphorically here, who don't speak their language. So,
okay. Thank you, Victor. We're caught up again on the question.
All right. So now we talk about assessment, and this will get into some of the couple of questions we had earlier. So the county will have to describe how and where will counties assess beneficiaries for medical necessity and ASAM criteria placement, and how will counties ensure beneficiaries receive the correct level of placement. So this goes back to what I was talking about, the county oversight in client entry into and movement through the treatment system, but also it raises some operational issues that who would do this? Do counties do it or do contractors do it? And in any case, somebody was saying that this cannot become a barrier to access, and where the situation will come in could occur. So somebody calls, the Acme Outpatient Counseling Center, says, I think I want to see a counselor. And so what do they say? Well, hang on the line, we're going to do a 1-hour ASAM interview. Or they do come in and they say, well, no, you're in the wrong place. You have residential instead. Or, you make an appointment. We'll come in on, next Tuesday and we'll, So the issue is, how do we do this and do it in a way that we respond to the best interest of the client in treatment, but do not create a barrier to access? And I don't know that I've got an answer there. Because we definitely want to have no wrong door. We want to have many doors, but we don't want to put the client through the ringer by saying, well, yeah, we can do the intake here, but you got to go somewhere else for treatment. And so it's going to be I think a real challenge in implementing the waiver. And the role of ASAM in all this is to do this in a way that does not stand between clients and easy access to treatment. And that I think will be the real challenge. Do you assess first and then admit, or do you admit first and then assess? And like I said before, I don't have an answer to that one. And we're all, that's going to take some thought by everybody, by counties and their providers, on how to best do that. And frankly, through this whole waiver discussion, this is just me, but I would like to have seen a lot more client involvement. And I think that's a question that needs to be put to people who are in treatment or who have recently left treatment. To get them engaged. If anybody should be on that advisory committee, it's folks who are actually current consumers of treatment services. But anyway, so that's the issue. No wrong door, no barrier to access, and how do you balance that against the need for correct placement in the right level of care? All right. There is the option in the waiver, and this is been talked about, although it's not restricted to this, but discussed as an option for the smaller rural, frontier counties, and where a group of counties could come together and jointly finance, say, residential treatment, and something they wouldn't have enough money individually to do, but could, as a group, come together and provide that. So again, it's a question, in some of the smallest counties, the county is the provider, you got 3 counselors on staff, and you've got these same issues to access, where half the population lives over the mountains. It's a 2-hour drive to get to treatment, and if you ever, anyway, it's a big issue. Part of it is financial, part of it just has to do with the geography. And I think, small counties may be coming together to discuss this, and may need some special support or other structures. Simply doing things on a regional basis helps to maximize the resources, but you still have, real challenges in getting clients from point A to point B for treatment services. Case management. That's a new benefit, and so how's the county going to do this? How will they be integrated with mental health and physical health? And the question here, I think, I give everybody a helpful hint here. We probably know what the primary needs for case management are going to be. It's going to be housing, employment, health, legal issues, maybe education if employment's not the case. And maybe what that would mean is, contracting for case management services with some centralized or a single entity, so you've got folks who can really, become expert in housing or employment issues, rather than, you've got a case manager at each outpatient or residential fever program, and they've got to go through and learn all this themselves. There may be some advantages to centralizing this function. But that's, again, each county will need to figure this out, what works best for them, whether to centralize the service and hence centralized expertise, or each provider figures this out on their own. MOU, again, this is...
Just one note, Victor, if I could just jump in. Just remember that now case management is a required and now reimbursable mode of service under the waiver, and so this is a big deal. We've been advocating for many years to have case management included as a reimbursable drug Medi-Cal service, and we're finally now, yeah, I mean, this is something that's long overdue, but it's important that case management is now going to be a benefit, a drug Medi-Cal benefit.
Yeah,
around the case management.
You had a question about it, Will?
Yes, there are a couple of questions came in around case management. One is, if the county wants to offer case management services, would the county have to get certified?
If the county's running their own program, you mean? Drug Medi-Cal program, I'm assuming it would have to be.
Yeah, it doesn't specify. Maybe the questioner can clarify. I'll ask the second question. Or go ahead, Victor.
Well, that's an interesting point, because if you're going to build drug Medi-Cal, you got to be a certified provider. So maybe case management won't work as a standalone service, and it has to be a component of, IoT, NTP, residential, outpatients, one of the existing modalities, or one of the modalities allowed under the waiver. So, and then it just becomes a billable service unit you would provide within a particular modality. But yeah, you're right. You can't bill if you're not certified.
Okay,
you may not be able to.
And I apologize for the background noise. I'm going to ask this question quickly. Will a client need to be open to another service to receive case management services? So you were talking about that the provider needing to be certified of case management. Now the question is, does the client need to be open to other services for case management?
Well, that's an interesting point, because maybe not so much for case management. I would say probably yes, but we get into that issue really with recovery support. This presumes that somebody is no longer engaged in, what we call treatment, and this is, continuing care. And this, of course, leads us into, CalOMS and this sort of there's not an array of requirements we have, because we've got to discharge people, because CalOMS says we have to discharge people. And so, and can you bill for somebody who's been discharged? Probably not. County billing systems are not set up to do that. So it's, there's some question marks there about what has, what do we call these sort of clients? Are they active? Do you have an open treatment episode in your billing system for somebody in recovery support? So does that mean you don't discharge them in CalOMS? Or what? But again, you've got to be, services have to be provided by a certified provider. I would think, again, recovery support probably is going to have to be, provided by one existing modalities will probably, but not be certifiable as a standalone service, but maybe. I hope that answers the question. I mean,
that's a really good question.
Answer to that.
There were a couple other questions, but they weren't related to this topic. So I don't know, do you want me to read them to you and see if you want to address them later, or do I go ahead and, or wait for another time?
Oh, well, why don't you ask them?
Okay. How does assessment fit into NTP program?
Well, I would say it's it's the same way it fits in anything else. I mean, you know, there needs to be some sort of a structured interview with the client to determine whether their substance use disorder is such that NTP services is the right level of care.
It's based on medical necessity. If they're determined to be necessary for them to receive that service, you know, then they would be entitled to it. But yeah, I mean, NTPs are like any other mode of service that have, you know, person would have to be assessed as needing that, having medical necessity for that.
Okay, and the other one is, will the IOP group caps remain in effect under the waiver? What are the group caps for residential?
Well, that's the group caps for IoT and ODF they've recently been changed. They used to be minimum 4, maximum 10. Now they're minimum 2, maximum 12. For residential, that's a piece of the waiver that would require an exception to the IND exclusion. If the waiver terms and conditions are approved by CMS as they are submitted, it would allow for residential, short-term residential, that's 90 days or less, to be able to be reimbursed by Medi-Cal, not limited to the 16-bed exclusion. So there's no limit actually on the number of beds, but there's only limit on the number of days.
Now back to case management. Another angle on this case management service. This is on the provider as the individual. So now the question of the provider, the actual individual provider, not the agency. So if case management service is standalone, does it require a licensed person or AOD certification or master level degree? Any discussion on that?
Well, see, I would think right now in a drug Medi-Cal, certified counseling staff are required. So, I mean, they're required anywhere, whether drug Medi-Cal or not. So these would be certified. There would be, I don't think there'd be any, we haven't seen anything so far that we would require a licensed, you know, MFT, LCSW, LPCC staff to do this.
Okay, and someone else said that they believe case management should be provided as needed for all levels of care.
Oh, I think so, yeah. See, I mean, that's, yeah, if it's medically necessary, if it's in the treatment plan, there you go.
Now, another question about NTP services. How do we avoid stigma in referring to NTP services with combined DMC services? Would NTP services carved out, without NTP services carved out separately, access to NTP services may effectively be limited due to extreme stigma against methadone among SUD providers?
Well, I recognize that there is some stigma attached to NTP programs, but nevertheless, you know, this is an entitlement program. That's a required mode of service, and you know, it has to be provided. If a beneficiary is assessed as being medically necessary, that they need NTP services, stigma or no stigma, that service has to be provided. It's an entitled service. So, you know, while recognizing that the stigma still does exist, you know, entitlement kind of trumps everything.
Right, and I think there are also ways to monitor that. You know, I mean, if an NTP is, over the last few years, is, you know, average of, you know, I don't know, 20 intakes a month, the waiver starts when they go down to 10. One might ask questions. Also, we could tell from Cal OMS, and this is some data we know from the Prop 36 evaluation, that people who are using opiates generally tend to not do very well in residential or outpatient treatment. And again, Cal OMS would see that if we're, you know, the level of referral for opiate users drops to NTPs and increases in, say, residential treatment, and these are the same folks who drop out of the program early. You know, it's pretty clear what's going on.
Yeah, and given the epidemic of prescription drug abuse and now heroin, increase in heroin abuse, I mean, it's, you know, absolutely we're gonna need more NTP treatment, not less. So I would be, you know, I would be very skeptical of receiving NTP admissions. I think that this is a program that's we're likely to see increases.
Now I got a series of comments and questions related to the group size discussion residential facilities. So I'm going to read all of them and give you a chance to respond. Let's see, let me start. So here's a comment. The new group caps have eliminated the community group, 12-step groups with all participants, and now you have to either not do it as a billable service or parcel it into 12-person groups under IOP. People keep saying IOP, so that's one. And then another one says, I think Tom's answer about residential missed the question about group size within the residential facility, 2 to 12. And then one more where someone tries to answer that. Speaking to the group size, the emergency revisions state ODF is to have 4 to 10 in a group. DCH only can run the 2 to 12 in a group. Please clarify your statement that the 2 to 12 applies to ODF.
That was changed by legislation. SB 1045 became effective on January 1 of this year. That changed the group size from 4 to 10 to 2 to 12. It is not yet. That has not yet been included in the state plan or in regulations, but we've been told by the department to let providers know that they can start billing for groups 2 to 12. And that 2 to 12 is now pretty much consistent across the field. So the question, I'm maybe not clear on the residential because I thought they were referring to the IMD piece. If you're running groups in a residential setting, those would, I'm assuming, also be subject to the new the group size, which is now 2 to 12.
Yeah, that could well be, because in the waiver terms and condition, it spells out the specific services provided both in intensive outpatient and in residential treatment. And, you know, if they're applying and I have to say, for the sake of this discussion right now, that IOP and residential kind of operate the same way. So we've got this multi-hour unit of service, which historically has just been billed as one package. The state is saying, well, that's good, but inside the box, we want to see these components. And they have said for intensive outpatient that the group component, now with the new legislation, has to have between 2 to 12 people. I haven't heard anything about this applying residential, but I would not be surprised if it happened. But again, that's speculation. But we've seen that happen in IOP right now.
I still have more comments, but I've also had a request that you complete the implementation plan, and then we continue with the questions. So
maybe we ought to say questions.
Yeah, let's finish this up, and then I'm going to have too many more slides left, and then we'll get to the questions.
Okay, go ahead.
So, all right. So memorandum of understanding, I mentioned that earlier. This is between the county and the managed care plans. Most counties are two-plan counties, so we've got the county health plan and then a private plan. And again, the option is for counties to add on to the existing mental health MOU. I think this is something that even if you're not in phase one, and if you're in phase one, you should be writing away on this. But it would be good to have anyway. To be talking with your health plan and talk about how do you coordinate care, refer clients back and forth. Telehealth. I think this will be very interesting. Again, could be a great option in the smaller counties. Also because the waiver, and correct me if I'm wrong here, Tom, I haven't seen these words for a while, but it appears that the waiver will allow counties to do rehab option services, that is, they can bill for services that are provided at somewhere other than the certified facility.
I haven't seen that language specifically. I do know there's language around telehealth, but I haven't seen the I'll go back and take another look. I haven't seen the language specifically that services can be provided outside of the clinic model.
Okay. So maybe that was in an early draft and is not there anymore. But anyway, so telehealth could be a huge benefit, particularly in small counties, and if we can use it in other in the rest of the system, I mean, I think for certain types of services, case management, recovery support, using social media, etc. I think there's some pretty challenging confidentiality issues there. This is related to stuff like authentication. You just send somebody a tweet. Did it go to that person? Are they the one who is reading it? There's data security, and transmission. So, if you send somebody an email, if they don't delete it, is there something potentially, anyway. But it's that kind of issue to maintain confidentiality in this type of electronic communication. Contracting, again, this is now selective contracting, a big part of this waiver. The counties can choose who they want to do business with as a drug Medi-Cal provider. This is a big change. And what is that process? I think that means RFP. How do you solicit participation? How do you set forth the quality and performance standards that you expect providers to meet? There's the local appeal process. Now, we all know about those. Those, I think, happen both formally, is what the state wants to see, but it's also informally, where somebody doesn't get a contract or they don't like what they earn from the county, and, they're on the phone to the Board of Supervisors. The county's being mean to me. I'm a small business, and I contribute to the community, and they don't want a contract. So, counties really need to be on a firm ground here, and I think some people early on thought, this is our chance. But there's a lot of controls in there, a lot of process involved. And if a current drug Medi-Cal provider does not receive a contract, then the county's got to say, how are they ensuring that this does not harm beneficiary access? And that's, again, a huge issue that CMS takes sees as very important, and that they expect the state to take equally seriously, which will roll down to counties.
And especially because in the opt-in counties, there will be no direct state contracting with providers.
Yes.
So
thanks, Tom.
The providers cannot run, cannot go to the state for a direct contract if they don't get a contract with the county. But the flip side of that is, as Victor said, the county does need to explain how it's going to assure access.
So, all right. Other elements coming to the close here: additional medication-assisted treatment. This is beyond the NTP requirement, and this would include buprenorphine, antabuse that would be available through drug Medi-Cal, as well as things like Withdrawal, which are available through the regular Medi-Cal pharmacy benefit. County's authorization process for residential, again, and Tom make his piece here, but we don't want to create barriers. So, and Tom, you've got a CBHDA comment there.
Yeah, just a quick note. Resident authorization for residential is required. The counties would like to have the option, if they want to be able to authorize for other services as well, to leave that as a county option to broaden authorization more generally. if that's what the opt-in counties want to do.
Okay.
That would be our recommendation.
And then rate setting?
Yeah, was this my slide or you? I think this was your slide.
Oh, okay. Well, anyway, counties are required to provide a rate range or a standard rate for all modalities. Counties have some flexibility here. The big question mark is kind of the overall financing and how much money counties will have to work with to do this. This is a specific instruction in the second one. Somebody asked a question earlier for residential services that the rates cannot include room and board expenditures. This is something that's a requirement right now in perinatal residential. There are models out there for how that is. Somebody I think asked a question about that. There are different ways you can go about this. I asked a question of DHCS, and they were, because you can get pretty, you just take out the food budget and the, whatever the cost is for the overnight staff. I mean, it's tough to say how you get to that. But I know perinatal residential providers have been doing it for some time, and there is a model out there for how that can be done in a way that passes audit. So I'd recommend if you know anybody who's a perinatal residential treatment provider is to talk to them. And level 4, withdrawal management, that's inpatient hospital. That's a current benefit under regular Medi-Cal right now. And then, Tom, I think this next one is yours. This is the benefits of the waiver.
Yeah, the next couple of slides are mine. You know what? For the sake of time, because we're running toward the end here, I'm not going to read through all of these. By way of summary, I just listed some points. The benefits of being able to participate in this waiver, enabling counties to have the resources and the ability to provide an organized and quality system of care under drug Medi-Cal for beneficiaries. I think that's just an overall summary of and people can read through these on their own. But there are some definite benefits to counties as well as additional responsibilities, but certainly definite benefits to opting into the waiver. So I think I'll just leave it at that.
Okay. And you've got the slides in your packet, so you can take a look at those, and maybe if you have questions, ask those, follow up by email afterwards. Into the last part of here, of course, the most complicated stuff for last, but that's also the briefest, is there's some draft amendments, revisions to the state county drug Medi-Cal NNA contract, and we could send that out to folks. That outlines further details for implementation. And one of the big things it does there is requires compliance with a new set of federal regulations. These are regulations we've not really had to do anything with before. These are related to managed care. Well, I'll talk about those. But, for example here, the section on beneficiary problem resolution is 7 pages of new language. The beneficiary brochure and provider list section is 3 pages. Cultural competence plan is only 4 lines, but a very important 4 lines, and it references a whole chunk of federal regulation. So I recommend that people become conversant with those, because it does talk a lot about, beneficiary rights and, grievance procedures and such, that is something we've not really dealt with in the past very much. The federal regulations, this is 42 CFR Part 438. The title is Managed Care, which should communicate something. This, I might add, also governs a lot of the operation of the mental health plans in counties. Again, another kind of stepping stone as drug Medi-Cal may move to the mental health plan. And I'm just going to talk about these are the sections here. Enrollee rights and protections, quality assessment and performance improvement, which contains a whole section on access, on operational standards, measurement and improvement standards. There's external quality review. These are the EQRO that the mental health plans have to deal with. There's additional provisions here. There's the grievance system, certifications and program integrity, sanctions, and conditions for federal financial participation. These are federal regulations. These are something that are going to be new, new rules of the game, and are not something that are in any way negotiable. That's just what we got to do. So, like I say, I recommend everybody becomes conversant with those. Again, we can send out a version of those or send you a link where you can access this on the federal website and take a look at those. The contract is in draft form. That may, that could still change. But again, we'll give an idea of what's up ahead. And finally, with implementation, we've got phase one. The state wants to implement this in, I believe it's 4 phases. And phase one will focus on Bay Area counties, which extends from San Benito, Santa Cruz, Santa Clara, Alameda, Contra Costa, Solano, across to Napa, Sonoma, and Marin, which includes 21% of the state's population. The planned start date is somewhere between April and June 2015. Phase two will start to be determined. I think the state would like to do these in 6-month increments, but who knows? This is a big one that includes 61% of the state population, some of the state's largest counties. So it's probably wise to start out with large but not huge counties. So that's it for my comments here. Should give you an idea of how this is going to roll out, what it's going to require, and particularly we can make available some of the source documentation here, which would be helpful, even though it's kind of heavy going, but helpful in understanding what the new requirements are going to be and what that means both at the county and at the provider level. So, Will, if there are more questions, I know we're kind of coming to the end here, but I'm willing to, stay with it for as long as it takes.
I want to be aware that it's 11:30, which is the time we said the webinar was going to end. So you've concluded your presentation, but there are some questions. So if people want to stay and listen to those questions and those especially ask them, you're welcome to. We'll try to cover them, not too long. Go for some quick answers here. So there's one about, can an individual be enrolled in an outpatient non-IoT modality and methadone concurrently?
The question is, the issue is whether you can bill for more than one Medi-Cal service in a day, and that's a state restriction right now. Although we've heard, we haven't seen anything in writing, but we understand that there's some efforts being made to change that, so that you can bill for more than one Medi-Cal service in a day. Right now, we have nothing official about that, but we have been talking to the department. And apparently there are some moves to change that.
Okay,
so yes, that could. Yeah, stay tuned on that one, because you could, some people may need to be involved in more than one service. Absolutely.
Okay, now Prop 47 is increasing the need for service providers and expansion of services. We need to address the need for more services. That's a comment.
Yeah, that's absolutely true. Prop 47 is going to have an impact. In terms of,
right.
Go ahead, Victor.
Oh, and of course that gets back to Tom's discussion of the certification process. I mean, right now it's taking, anywhere between 1 to 2 years to get a certification application approved, and we need to be able to ramp up programs more quickly than that. and for capacity. It's easier to do, relatively speaking, on an outpatient basis, but for people who, with greater levels of impairment, who need residential care, it will be a challenge.
Now, someone else wanted to share that in their county, they created a policy that SUDS providers cannot discriminate on clients that are prescribed NRT, and the state should set the same policy requirements.
They can't discriminate against people who need narcotic treatment, you mean, like methadone? Narcotic replacement therapy, right?
Yeah.
Yeah, that's true. Can't discriminate. Counties can't discriminate. We realize there are some counties who have had, you know, an issue in terms of not supportive of methadone treatment, but any county that opts into the waiver have to agree that they can no longer, they can't have that kind of a stigmatized view. So, and a county that doesn't opt into the waiver, that service still has to be available. It's just that it would have to be maybe directly contracted between the provider and the state.
Okay, we'll keep going. We need to know if we can provide in-home therapy for families and perinatal programs, or does that therapy also have to be performed on-site?
Well, that's a rehab question. Yeah. Go ahead, Victor.
Right, that's just what I was going to say. You know, it's whether that rehab option is indeed part of the waiver or not. But again, home visits, there's a long history, research on the value of doing that kind of service.
Yeah, it's a great question. I just got to go back and look at the final version of the terms and conditions to see what. I just don't recall seeing language that allows for the full rehab option.
Someone else was asking about the provider choosing process. Does this have to be an RFP, or can we choose the process based on our local standards?
Well, it definitely can be an RFP. What other? I'm not familiar with other.
It doesn't have to be an RFP. I'm not sure. Yeah.
The counties have the ability under the waiver. They have the authority to select their contract providers. I'm assuming that, because it's not further specified in the terms and conditions, that counties can use whatever their planning process is to be able to make those decisions. Again, they just have to be able to assure. You have to explain that in their narrative and how they're going to assure access.
Okay. If room and board is not included in residential, why do they continue to refer to it as residential, which includes housing the client? So just a clarification of what is being paid for room and board when you say that housing is not included. There's some confusion around that.
Yeah, the Medicaid, not just Medi-Cal, Medicaid will not pay for room and board. When we talk about residential, we're talking about residential treatment, the treatment that takes place in residential facilities. The room and board have to be paid with, through block grant or other means.
So the clinical services provided, the treatment services provided.
That's correct. And that's not that's not a state issue. That's a federal requirement.
Mm-hmm. Okay, and then someone asked Victor that you send out a sample cost report that includes residential, if you could. And then
cost report.
Yeah, sounds like, can Victor send out a sample cost report that includes residential? Maybe you're not able.
Maybe they could send me an email.
Okay. And then, are you including non-county community-based providers in your discussions? All this looks very county-sided.
Well, I have to say it is. This is between the counties and DHCS. What I've tried to do is to, where indicate where there has an impact on providers, and I think there's some things like selective contracting where the provider impact and interest should be pretty obvious. But whatever the state requires of counties, it's going to roll down the provider level. When in those counties where they contract out services. So cultural competence, if it's a contract county, then, you know, that's fine, but the people who actually have to have that linguistic capacity are going to be employees of nonprofit community-based provider organizations.
Okay, do Phase 1 counties have to sign up in Phase 1?
Do what counties will? What was the question?
Do Phase 1 counties have to sign up in Phase 1?
No. They only would come online if they believe they're ready to do so.
So they could come in line in Phase 2 if they wanted.
Yeah. Yeah, the department's fairly flexible about that. I mean, what it's saying is we would like to have the Bay Area counties because, you know, their close proximity and you know, we feel like most of them are ready to go into Phase 1. There's not a mandate that every Bay Area county enter into Phase 1 if they don't feel like
there's a limitation that you have to enter in that window, and if you don't, then you can't enter.
No,
right?
there's counties. There'll be other opportunities for counties to opt in.
There are extremely few perinatal providers. Oops, someone said for that exact reason, but I'm not sure what you were referring to at the time. So let's go on. What are the program regulations? Where are the program regulations located? Will there be a new Title 22?
Well, there will definitely be changes to Title 22. You know, the regulations generally, you know, follow the statute or state plan or in this case waiver. I don't know when the department's planning to make those changes, but I think eventually there will be changes to Title 22.
So are they saying that they're making changes? Because I thought before it was as if it was trying to happen without any changes to regulations.
Well, I think they are because it's a waiver. You know, it kind of trumps what's in regulation. But I think the expectation is that once the demonstration has proven itself, you know, that there will be appropriate changes made in the regulations. But that's not an immediate issue for sure. I mean, that's something that's we're looking at for the future. The idea is you're not, if you're in the waiver, you know, you're waiving a lot of things, including, you know, regulations. So you're not bound by the regulations. The waiver trumps that.
Okay. All right, that helps clarify that. And then can you provide the link to the state, county, DMC, NNA contract revision? Did you say you were going to be sending out a bunch of, sending out some documents or resources, Victor, or?
Yes, Will, I can send those to May after we're finished here, then she can email them out to folks.
Okay.
So either documents or the links.
Okay, that's good. Now, someone else was asking about the phasing again. They said, I thought you said earlier that counties who are ready to opt in would be first. Now, why the regional phase change? Why did they go for regions instead of the original idea of just who's ever ready?
Yeah, and I don't know that the department's so hard and fast on that. It's a good question because, I mean, that's a departmental decision. That wasn't something that we asked for. I'm under the impression, and again, this is just my impression, that the department is somewhat flexible about this. If you are not a Bay Area county and you feel like you're ready to come in Phase 1, my impression is that you know, the department would allow that. But I think that's something that the county is going to have to take up directly with the department.
Okay. I have a few people thanking you when it was 11:30. That was informative and very helpful. Thank you. Great job with Prop 47, Tom. Still a couple questions, though, after the thanks. Do you have to be a licensed facility?
Residential, you have to be licensed. And if for drug Medi-Cal, if you're drug Medi-Cal, you have to be certified as a drug Medi-Cal program.
Okay.
But license apply. Go ahead.
Okay. I'm sorry, I'm just trying to move through quickly, so I apologize.
Yeah, licensed residential and certified, you know, everything else.
Okay. And then PowerPoint, will it be made available? Yes, we will be sending it out to everyone who registered. Someone would like to be directed to where they can get more information specifically about the waiver and the pros and cons of opting in. Can you redirect me to a resource, please?
Well, I don't know there's a document regarding the pros and cons, and I think each county is going to have to, you know,
all this is evolving very quickly, so there aren't that many resources available. But we are going to try to send out what resources you do have on the waiver, right? And then in the PowerPoint, and then I think someone could be free to contact you, Tom, or Victor to kind of discuss the pros and cons, right?
Yeah, we have a lot of materials on that.
Okay. Someone wanted to know if the waiver had actually been approved yet.
No, they're hoping by the end of March, by the end of next month.
By the end of March, because that's when the time frame was.
That's what the time frame. I mean, CMS could can approve it tomorrow, but they most likely will take close to the full time.
Okay, last two.
Not been approved yet. And I got to get going, Will. So.
Okay. Well, Victor can handle last two questions. Phase 1, April through July. Is this the time frame for the counties to create their plan for those who opt in? Do those who don't opt in have a time frame in which to have all the services provided? I think they're trying to understand what is in the time frame for. What is the April to July? Is that when they do their work, or is that when they submit their? Can you kind of specify what that time frame is about?
Yes, let me see here. Well, you know, they don't really say, so I am not sure whether they're going to, even within phase 1, you know, whether every county jumps in all at once, or they will, you know, plan by the end of 4 months to have everybody in. So it's not really clear. I'm just looking at a matrix we sent out, which says, you know, timeline April through July 2015. So it's not a whole lot of detail there.
Okay, and so it's not clear what is meant for those phase periods, those time frames. And the last one was: is the goal to have the counties do the certifications for the state so they can better monitor compliance more frequently? Just trying to get a sense of what was going on with the county certification.
Well, it's still not clear whether, the last I heard, and like everything, this is, you know, particularly subject to change, is that the state was going to retain authority for issuing the certification. And the understanding was that that's a requirement under federal regulation. Nonetheless, counties could play a role in the certification process, which might help expedite certification. The specifics of that are not yet available and may still be under development. And that's part of the discussions between CBHDA and DHCS.
Okay, and I'm going to wrap this up. We did get one more question, and I think we'll close on this for those of you who have stayed on. Several people have left already because we're over time. But someone was asking about how would stakeholders, say, compel their counties to participate in the waiver? What's the process? I'm thinking maybe you can guide them in terms of what's the role of kind of stakeholders in really communicating to the county. Well, I don't have to translate. It says it there. Compel their counties to participate in the waiver. Yeah. What's the stakeholder role in that?
Well, I tell you that I can answer that question very specifically, but you know, I would first off, you know, just because a county might be in phase 2 or 3 does not mean that they should not be thinking about all this stuff now. And you know, you don't wait till the you know, your number comes up in the implementation plan before you start thinking about your community stakeholder process. So, you know, if I were a provider, I'd be asking about that question now. So who's on that? What role do we have? As far as being able to compel the county, well, good luck. I think the big question here for many counties has to do with the financing. You know, additional benefits means paying additional claims, which means more money. And the state is still working on that, what they're calling the cost-sharing ratios, how much comes out of the limited and capped realignment funding the counties have, and how much may be contributed through additional state general fund participation, and that still is unknown. And frankly, I think that's probably why they gave 4 months for this phase 1 implementation process. Is that counties need to know if there's any risk, and if the county auditor controller or the executive office does not get very clear information on the degree of financial risk, they're not going to, a recommendation to the board of supervisors, which is ultimately where the decision is made, they're not going to recommend that the county participate if it looks like they might lose money.
Okay, that's it. I'd like to thank you. I think Tom has left us, but I'd like to thank you, Victor and Tom, for helping us understand and digest this rapidly changing and unfolding information about the waiver. And thank you also for being available for folks who might have additional questions. And we will be sending everything out, the materials that we can, and once this webinar has been processed and recorded and uploaded, we'll also send you that in case you want to share it to someone else as well. So thank you all, and we'll keep you posted about the next webinar.